um, give you a perspective on what we've learned from our work with the SCN so far. Hear your perspectives too, because some of you in the Zoom room here are what we call the option two practices, where you're doing screening at the practice level, and some of you are option three, where you've kind of asked us to do, to do all of that participation. And we really want to be learning from you as well. So we kind of divided the presentation up. I'm going to share my screen. We're going to tag team this, Chad, Robin, me. And don't hesitate to speak up or add to the conversation if you have a question or if you have a point you want to make. Our hope is to cover a fair amount of ground in about 30 to 35 minutes and leave some extra time for questions. We will definitely conclude before patients start again at 1. So let me just share my screen for a second, just for some reason impossible for me to do. There we go. And once you can see it, let me know. I got to get it into the actual slideshow format.
We can see your screen.
Okay, great. So this is our plan for the agenda for today, and we can certainly add things if you have other questions, but we want to make sure we review the process, what improvements have happened in the process, sort of our collective lessons learned, talk about it, and how it will inform our work going forward. As a reminder, the waiver continues through March of 2027, so we still have a little more than a year left in this work. From that conversation, we want to move on to talking about what we see as sort of the immediate and long-term next steps for AHP with our practices. And then we also definitely want to leave time to provide information to you all about practices or individual providers who would want to register for the Healthcare Access Loan Repayment Program, which is also part of the waiver that was just rolled out this month. So that's our plan. And I guess I'll start right off. We're gonna break it down talking about the 3 components of the screening and connection to services part of the waiver. And you'll see the word complicated, I think, or cumbersome sort of shows up a number of times. We have definitely found that this is complicated, more than what we would love for it to be, but we're in it to try to continue to work with you all on doing the best thing for our patients and honoring some of the work of the waiver too. So if you just look at screening alone, the process for screening can actually be relatively straightforward, but we have, I'm putting a lesson learned right at the beginning. It is better as a universal approach at a practice level, we think, or for patients who are presenting with an acute need. And so we'll explain that a little bit. In terms of improvements that have happened along the way, I think that any of you who've been involved in this, particularly if you're screening at the practice level, know that there have been a gazillion changes that have happened over this year. I don't even know what iteration of the program guide we're at right now. Is it 7, 8? Is it 9 now, Robin? I'm not sure. But the state continues to make revisions to things, and some of the revisions have it seems to have moved the process backwards, and some have moved the process forward. So we're really talking about forward progress. For those who are doing screening, you'll know that the Accountable Health Community Screener, the AHC screener that's required by the state for this work, is actually there's a shorter screener and then there's a longer form. And midway through the year this year, it was being emphasized that the longer form needed to be performed for all patients being screened. That longer component includes lots of safety questions. And so it became a big barrier for patients being screened over the phone, where you can't assess if they, really can give an honest safety response. Or are you putting them at more risk? It became complicated for practices that were screening, but were not looking at the screener immediately, doing it through their platform or sending the screener out in a different way. And so that has been reversed. There is not a need to include the safety questions. It's just the basic social drivers of health form of the screener. And that really helps make this more efficient and I think more focused. It's not that safety is not important, but we need to do that in the right setting. with the right responses. The other piece that's new and really important, and we've got confirmation from FLIPA and from the state on this, is the first question with the AHT screener is basically, do you consent for this, I'm paraphrasing it, but for your screening information to be shared through the state platform at the state level. And what our team and others have found across the state is that is almost a stopping point for a number of patients who will be like, nope, I don't want my information shared. Thank you. And so what they have allowed now is that that first question can now be asked at the end. It still needs to be included, but the value of this, which you'll all understand, is it allows you to actually find out if someone has needs. And then if they decline to have it shared with the state, you can still help them with their needs, but you haven't stopped the whole process at the beginning. So those are two things we think are positives in the screening. What we've learned from this, and I'll just remind you for those who are option 3 practices who asked for AHP to do the screening, we had what we thought was a really clever approach to this. We decided to start with a patient roster from all of those practices for patients who would have a complex need that would actually put them in the running for qualifying for this. And we were using asthma in the pediatric space. We were using other complicated medical conditions for adults. But we were effectively doing a cold call. As we pulled these patients up, our social work care management team was calling these patients. And we have just found, even with these, like, we have such a skilled team of people. Robin leads for all of us, and you could not have better people calling you to ask you sensitive questions. But there is just something about cold calls in this day and age. I mean, I wouldn't answer the phone. Even if it was Robin on the other end, I might think about it, but you don't know, right? So right from the beginning, we had people not answering or declining very quickly. And so while we still believe that that type of screening can be enhanced if we're using qualifying conditions, it's not as good as screening that would happen at a practice level or screening that happens in response to an acute need that's being presented from a patient. So that's what we've learned. I just want to pause right there for a second and just ask from the practices that have been doing screening or those who've participated with us in option 3, if there's anything you want to add in terms of your observations or lessons learned on this, just the screening component. And I can only see about 5 of your faces. So, all right, I'm gonna keep.
So, wait, I can answer you, Dr. Shipley. This is Karen.
Thank you, Karen. Yes.
So we do screening in the office, and we have a green sheet. We use question 0 because the MedEnd version doesn't have question 0 on it. And it's right on top, and they permit or deny. And we try very hard to explain to them up front, that this is a grant, that this has a lot of things in it. There's a lot of great work being done with it. But they just have to say yes or no. And I still have a significant number of people, even with needs, unfortunately, saying no. And it's so sad because, especially with food insecurity, if you were on Thursday's meeting, they have amazing programs. So I'm looking for anything that can tell me how to get these people to understand this really is to help them.
Yes.
Because even on our level, it's definitely, in a lot of our populations, a fight.
Yeah. I agree with you with that, Karen. I don't know, Robin, if you have suggestions in that space. Is one of the things that we're really working on. Like, the most important thing is to get people the services that they need. If they qualify for the waiver services, the level 2 services through the platform, that's great. If they don't qualify, they still have needs. And so I think really thinking about how we help people to feel comfortable with accepting the services and the help. I hope we can collaborate around that. Thank you for sharing.
This is Doug
Yeah.
Bennett. I'll
Hey,
give you our experience. We're doing the forms through our patient portal. So they're going out prior to well visits to all patients. And the first question is the question 0, whether they want to do it or not. And on my experience and our experience is that most of the people who say no, fortunately, don't have really any social needs that are going on. The ones who are saying yes tend to have the social needs. I think in any of them who say that they're positive and say no, I think we would address them independently just with our practice as well.
Yeah.
So I think we're having pretty good success. Having at least done once a year, but almost at every visit we're having them done.
Okay.
Yeah.
That's great. Thank you, Doug. I appreciate that. So you're using the portal. Karen at Goodman, you guys are doing, you have the screener and MedInt, but you're doing it with a paper
We
form?
do it with a paper form and
Okay.
then, because we screen everybody too.
Yes.
Just because I didn't want to single out a population.
Yep.
So we just screen everybody. Question zero is only on the Medicaid ones. We definitely don't use our portal because our portal doesn't go to so many people. So we just do it every patient at the well visit. That way we can capture our 12 to 18 and the people who aren't on the portal, which is a ton of them, of course. So, and then it goes into Flippa manually for the Medicaid people, because obviously no one else goes into Flippa.
Right. Thank you. There's no, I won't disguise the fact that I think that the best outcome of all this waiver work would be if we could have all of our practices doing universal screening. I think, you can't judge, just as you said, you can have someone on commercial insurance who is struggling with social drivers of health. And so, being able to meet those needs is really important. So I really appreciate those of you who have been working to implement this. We're going to talk a little bit about right now what future opportunities and considerations are in the screening realm. So one of the things that's important is throughout this whole process, they've been trying to build connections with the RIO as a way of being able to pull the screeners, if they're done in the electronic medical record, that to be able to actually pull that data through, and it goes through a data lake, and I'm using all kinds of terms I not know what that means at all, but then it actually can land in the Flippa platform. And so this is one of the things that they're moving forward now. They're working with Epic on this, and they have it working in some instances. There's a couple of MedInt practices we understand, not any of ours in our affiliate network, but some others that are starting to work with MedInt in that space. So this is something we want to keep an eye on. I think the only concern I have with that is we have to make sure, and you'll hear this repeated, somebody has to get eyes on those screens so that a provider knows if someone has acute needs, right? Especially if you're doing this through the portal or if you're doing it in the record. Just trusting the process that it's going to land in the platform and it's all going to come back around. That has not demonstrated that that's happening yet. There's not a full circle moment. So, but this is coming, and I think it could help really support this work for universal screening as they develop these connections. And then the last future opportunity is patient self-screening. So patient self-screening has been allowed to happen from the beginning. Patients could be given the website for Find Help Now. They could go in and they could do the screen on their own. They also now develop QR codes so that patients can, be shown a QR code. They can do an individual screen. The dilemma with this, I think this is a great opportunity, except it doesn't connect to anything. So basically that one of your own patients in your office, if you shared a QR code, that would go into the platform, but it would never come back to you. So you won't know what happens with your patient yet. We have asked specifically, AHP has asked for New York State to consider having the QR code link to a practice or to the CBO where the patient is being seen. They're contemplating that, but I don't think we're at the top of the list for requests. So we'll see what comes in that space, but it's something for the future.
Can
So,
we go back to the MedInt interface for a minute?
Yes.
Do you know the insane price they want for you to link MedInt to Flippa?
No.
It's like $2,500 and no one will tell me what I get for that. It's crazy.
That's great information. And let me take that back up with Flippa, because there are dollars for like EMR work and integration and data and stuff. We are limited at HP in terms of what dollars we can access to support practices. It just has things to do with the contracting. Most of the monies are supposed to go to CBOs or to folks who are directly doing, the screening or the connection. But My understanding is there could be budget for that. So that's a great question, Karen. Let us take that up and find out, because that shouldn't be a barrier.
I know,
If it
it
were,
was like, I couldn't believe the money they wanted for that. I'm like,
yeah, that's not cool. But let's see what we can find out on that. That's a great question. Did I hear someone else? So moving to the next phase of this, once the screening is done, eligibility and navigation. This is where those words of cumbersome and stuff just come up. I have to be honest with you folks. I think that this is the space that's a bottleneck for everybody. And for those who don't understand, once someone goes through the screening process, then there has to be time spent with the individual, patient or parent, to go through another series of intensive questions that are longer and more complicated than the original screening. This is a way of collecting data to make sure that the patients who are receiving these services are in fact eligible. They either have a qualifying condition, they're definitely Medicaid or managed care Medicaid, and that they have a need that matches what the waiver is intended to focus on, which the two big pieces are food insecurity and housing. Although there's transportation that can be also tapped into transportation resources, but not for medical appointments. So it's a little bit unique. So this process, Robin, help me out here for a second. This process takes at least 25, 30 minutes, probably.
I'd say a good half an hour, if not
Okay.
longer.
Yeah, per patient. And this is an area where I think everyone is saying it's just really, really cumbersome, and it's what's getting in the way of getting people to needed services. We have asked for every kind of workaround you can imagine, because I love a good workaround if you can't have a solution. And we've got nothing yet at this point, but we have heard that the state is talking about streamlining this process. FLIPA has suggested to us it may take until the spring before we see anything. But we are continuing to offer feedback around this, because if this process could happen more quickly, it could actually be done at the time of the screening potentially, or it wouldn't take this amount of time and person power dedicated to it. It is not something that a patient can complete on their own. I had asked about that as well. So even though you can have self-screening from a patient, you can't have the eligibility and navigation completed. So, ideally, we found by the screening that we were doing with our care managers that doing as soon as a need was identified, getting that eligibility and navigation done at the same time is the most efficient, because otherwise you're trying to call people back. They don't want to take more time. You lose folks along the way. Or at least having a very good warm handoff so someone knows they're going to be called about this next step is important. Future opportunities here, like I said, we're looking for any kind of a streamlined opportunity. It appears that we may be able to work with FLIPA on an approach that could allow us to assess eligibility for the level 2 services, meaning the housing transportation ones, up front. But it does not change the need to go through that 30-minute process for every patient. But at least you haven't done 30 minutes of work with someone who didn't qualify for that, and now you have to go back to do what you would have done originally anyway to get them housing and food. So I wish I had better things to say about this, but this needs to be fixed. It needs to be changed. And the state is aware, and hopefully there will be some changes coming. So I don't know if anybody has a comment on that, because I don't think anyone is doing their own eligibility and navigation who's on the call. Robin, would you add anything to what I said?
No.
Okay. Care management. That's the third component in this. Care management in this waiver work is much slower than in our traditional HP practice partnership with social work, care management outreach. And in our model, this is a space that we feel requires significant attention. So we avoid delays in connection to services and losing people in the process. We will say that improvements that have been made over the year is that more CBOs are being added to the platform. Efforts are being made on the part of the platform to assure that the CBO's availability is updated, because some of them are saturated and they're not able to serve more patients. And we have been told that more CBOs can be added, more services can be added to the platform. So that's an important thing. If you know of a service line that would be valuable to your patients in the region where you are, and it's not in the platform, letting us know so we can work with Flippa to make sure that they get that added, is a good opportunity. For our lessons learned, I think one of the biggest worries we've had is that for some of you who are option two practices where you've been doing the screening yourselves, there have been some significant delays after screening until that eligibility and navigation occurs. And patients, by the time we are getting connected with them, are then declining going any further in the process. So thinking about the efficiency of our workflows in this is going to be a really important thing. Probably one of the biggest lessons learned we have had from Flippa, because they're looking at all of the region and all of the referrals that are coming through that are qualifying. The vast majority are housing and food insecurity. There's very little that's come through that's qualified for transportation that is this non-medical transportation. So that has made us really think that's the space we should be focusing on. And you heard Karen talk about the number of resources that are available for food. There are many resources available for housing, and there are some that still are not present on the platform that our teams know about. But anyway, that's a direction we think we should be going. And then the last point about this is, I mentioned it earlier, but if a practice is screening, or if we're screening, right, making sure that there's timely review of the screen by a provider is essential. So we don't have someone with an acute need who does not get the attention that's needed. I think that's really important. For future opportunities and considerations, we're working with Flippa, trying to identify like the best streamlined approach that we can for patients with those two focused areas of needs. And that's where we feel like the waiver work with care management, that's where we want to try to capitalize, particularly if someone has an acute need, getting them into services as quickly as possible. And that's important whether they qualify for this level 2 work or whether it's just a need and they don't qualify, right? We want to make sure that anybody who is having acute food or housing needs gets connected. And so this is my chance to turn over to Robin, and I think to talk a little bit about, otherwise we also don't want to lose track of what was a really good model that you all were doing with our care managers in addressing these needs. So Robin, I'm going to let you talk about that. And then when you want that resource slide to pop up, let me know.
Sure. So I think we certainly have an innovative model, and then we've had it over a number of years, and it works wonderfully well in our practices. As many on the call will know, the majority of the work that the social work care managers are doing are in the complex spaces. So that is typically with those patients and families who have complex medical needs, sometimes intellectual or developmental needs. Certainly a significant portion of our referrals are those children and families who have behavioral health needs or substance use disorders, and many of whom have a combination of all of the above, including social drivers. So we think about, and I think my job today is really just to review that we have a wonderful, innovative model that works, that we don't want to lose sight of because we have this project, but that those patients who are certainly rising risk and in the greatest of need and the most complicated, where there's time and energy, action that needs to happen with those kids, those families, outreach, a lot of service connectivity and navigation of complicated systems. That is certainly the job for our AHP social work care management team. It's also done in the context of relationships. So when I talk about, some of the challenges that we encountered, cold calls are very difficult. But when we are receiving our typical social work care management referrals, the focus is on engagement and really building those connections and working in partnership with our care teams at each office to make sure that we're not missing anything and that we're communicating about all of the needs and our care management goals with those patients. So what I want to say is that our innovative model works. It hasn't gone anywhere. It is still there. And I also want to just sort of reiterate that the majority of our offices also lift a significant amount of sort of lower level social driver of health needs. They lift those referrals. They're interfacing with patients when they come in for their annual visits, doing some screening. Patients are saying, we have these needs, and the offices are stepping up and managing those. Whether that's a call to FoodLink or supporting some transportation that they need. We have found, I think this partnership over the years has been certainly in tandem with our practice providers and our practice teams and our front end staff to meet those needs. So, as we know, there are more than enough needs that our children and family and certainly adults are coming in with. How we sort of hand off to who can best manage those most effectively and efficiently with their skills, I think is something that we strive for with our team-based model. So there is a resource that after this call, we will email out to everyone. And that is a wonderful thing just to post. This slide here doesn't have all of the numbers, but we do have the one that I'll email out will have much more comprehensive phone numbers. It's a short list. It's not extensive, but it's the go-tos. Front-end staff, it's food, it's housing, it's transportation. If you're out of county and not Monroe, 211 is always the go-to. They not only have the most comprehensive resources across the counties, but they also have the most up-to-date information related to food for specific zip codes, housing in shelters across counties, even domestic violence services and things like that. They are also aware of where spaces are, where there are opportunities for someone to be housed if there is a need. So we'll send that out. And I guess the only other piece I really wanted to reiterate is that, the Flippa platform is still a tool for our team. It's not the primary tool that we use. We have a lot of resources and connectivity across our county and beyond, just in our commerce of our work that we do in this field. But we are finding where we can access some of these services, and we'll continue to try to do that on a limited basis. So if you have questions related to a child, a family, or even an adult, and you're not quite sure if this is one that should come to social work care management or it seems much more complicated, give your care manager a call and we're happy to talk it out, problem solve. Could this be a quick 1 or 2 touch situation, or are there a large number of issues that are resting right below transportation and food, and that would require much more extensive work? So just give us a call, or for those that do referrals in the EMR. Again, the standard way of referring still works. It works well, it's efficient, and we're going to continue doing the good work that we're doing with our partners.
Thank you, Robin. So just a few slides left, and then we'll leave time for questions. But so our recommendations for next steps as we head into 2026 with this work, immediate next steps for us is that we're going to continue to work with Flippa, trying to streamline the patient lists, identification and referral for those level 2 services, focused on housing and food, so that we can accommodate urgent referrals, and we can think with you all about how we get access to that. So as more of you are doing screening at the practice level, making sure that we have figured out the best pathway to be able to access those resources for patients. And as Robin just said, we hope that all of our practices will continue to share with their patients who need these resources for tier 1 level supports. And Robin's going to we'll send that information out to you along with this slide set after. And please do refer to AHP Care Management Outreach for your complex patients. And we'll continue working on them together. Long term. So what about by the end of this year, what would we like to see? I really do think if we can move to a direction of universal screening at the practice level for all of our practices, that would be great. We're not jumping both feet in on this yet, because we do want to see what the capability will be with the Rio, To Karen's question again, if there are outstanding fees or, charges that are being made by certain EMRs, let's take a look at that. But it seems to me like this would just be good medicine overall, for us to be able to operationalize this. But we don't have the answers yet. We'll stay in touch with you all. And our thought was to meet again in March, review progress, see what's changed, just do a quick update and kind of keep this going for us every couple of months with this core team, you folks representing your practices in our group that's working on this. So I'm going to pause there for a second. I still want to tell you about the loan forgiveness program, but I just want to see what questions or comments there are. Chad, to give you a chance to say anything else if you want to add things.
I have a
You guys
question.
definitely have been more in the thick of it than I have, so not much more. I think the big thing is, not surprisingly, one of the things we found out is this is damn hard. And truthfully, the reason we took this on from the beginning was we wanted to try to unload some of what we anticipated could be kind of a heavy workload for each practice individually. And we found that at least to this point, no surprise, New York State has not made it a very streamlined or seamless process. So I do think that has given us a little bit of a seat at the table. And I know, LJ in particular has been very engaged and involved both with the state and with FLIPA, trying to make amendments to expedite this. And I certainly think, her voice is being heard, which is helping. I think the big thing right now is, how do we limp through this period while the state kind of comes to terms with the reality of the situation, continue to do good work for the patients, but not make this an onerous thing when we all know that staffing is difficult and everybody's got, 1,000 things to do on their plate right now. So I think the goal was to obviously be much farther. The reality is kind of what we feared may be the case, but in some ways, I think that's why we're stronger together, in some ways. So, I think it's something we continue to work on. We continue to push on the places where there's opportunity for evolution with the state. And, in the meantime, as you guys find your own best practices, like we said from the beginning, we have by no means think we've got this knocked. We're just looking for economies of scale wherever possible. So more to come.
Thanks, Chad.
I have a
Karen,
question.
go
Yeah.
ahead.
So I've got a very confusing email and I was confused on the meeting, and Robin might know this best, but I thought that social determinant screening was done annually for people. I mean, things change, but FLIPA's new thing says, oh, if you did it and didn't find anything, there's no reason to do it again unless you know. So are we supposed to screen annually, or we only screen new patients? I'm very lost as I go into year 2.
Yeah, I have not heard that. Our understanding was annual screening, which I think makes sense personally. Things can change in a week, right? But usually
Right.
those people will come to you hopefully and be asking for help if they know that they can. I would keep it to annual screening. But I'm happy to follow up with the FLIPA team
Yeah.
on that.
Well, I asked FLIPA, I didn't get an answer. So it sounds like they don't want it put back into the FLIPA platform, and I guess that's what I need to know.
Huh.
My sense was that, it's for those screens that are getting reimbursed, it's annual. Or if there's like a qualifying condition, so some
Right.
change in living or, whatever the circumstances are, that then you could, because I think there are questions in the platform that, sort of walk you through, is this A, B, C, or D, and it's happened within the past year. Now you can screen again.
Correct. If you
Um,
have a qualifying.
Right.
But
correct.
the mandate, as I just understood it, not mandate, as I just understood it was once
Mhm.
you did it, like in
Mhm.
25,
Yeah.
unless you have a qualifying condition, don't do it in 26. And that's what confused me. You don't know.
Yeah.
That would
Okay.
be news. That would be news to all of us.
All right.
So we'll
Okay.
double check on that, Karen, just to be sure. Thank you for
Well,
raising.
I reached out to Kate and I have not gotten an answer twice, but okay.
Well, now we're all going to have that question. So I would say annual screening, do
Okay.
it, unless I tell you otherwise, because that's what this whole thing has been like. Oh my goodness. So just to say something really positive though, I just want to share with you guys, part of the waiver is the screening Part of the waiver has been to increase workforce, and part of the waiver is to support the active workforce. And so this is the thing that has just rolled out. So the Healthcare Access Loan Repayment, or HEALER program, applications are now open. I want to highlight that the applications for individuals, which I think would be what would be happening in your instance. There are employer applications that can happen, but I think that's for bigger systems. At the bottom of this, Sunday, February 15th, 2026 is the deadline for submission. So basically, this is part of the workforce initiative that's supposed to strengthen our capacity in assisting healthcare professionals in high need roles with their student debt. It's a 4-year full-time commitment to maintaining a personal practice panel or working in an organization that serves at least 30% Medicaid members and or uninsured individuals. And what's really important is that organizations that are contracted with a state designated social care network, which for us is FLIPA, your contract with FLIPA is either direct with them or it's through us, but it's with FLIPA. And, you know, participating in the social related or the health related social needs screening or referrals or services also qualify. So there's some specifics around qualifications that a practice not participate or provider who's not participating in the SCN, but who's caring for 30% patients, Medicaid, 30% of their population is Medicaid patients, they can qualify as well. But by virtue of the work you're doing with the SCN, this is a qualifying thing. So I'm just going to share really quickly what this means, and then we'll send out the link with the information. Don't hesitate to reach back out to me, but this could be an opportunity for those of you who have recent hires with student loan debt. This covers psychiatrists, primary care physicians, dentists, nurse practitioners, and pediatric clinical nurse specialists. We have confirmation from the state that primary care includes OBGYNs, pediatricians, and geriatricians. PAs, however, are not available. Are not eligible, excuse me. So that's one of the things that's a caveat here. And in order to qualify, there's a whole long qualifying thing. I just tried to pull out some information that was shared through University of Rochester Medical Center. But basically, citizenship, or there's certain eligible non-citizen categories that was not worth putting on here because it was very long. The individual needs to be licensed to practice within New York State currently or by the time their service commitment begins, license in good standing, commitment for 4 years we talked about. They have to have qualifying full-time employment. So this would not qualify for someone who's a part-time employee. They cannot have participated in other student loan repayment programs, and they have to have an outstanding balance due on an eligible education loan that was associated with the highest degree earned. So it you know, if someone had I don't even know, went from being an RN to being a nurse practitioner, it has to be for that nurse, the loan has to be for that nurse practitioner training, for example. So I think this is, you know, we're not sure how many of your providers or in your practices would qualify, but we wanted to be sure that this information got out to all of our practices and that people know that your practice teams are eligible, particularly if you've got some new folks who joined you. And that is all that we had for today. So just gonna